All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's episode is on epidural analgesia at the end of life. And our outstanding guest today is Dr. Sandy Christensen, an associate professor in anesthesiology and perioperative medicine at the Oregon Health and Science University, where she practices pain medicine. Within the field of pain medicine, she specializes in interventional cancer pain management. Dr. Christensen has been on faculty at OHSU since 2016 after completing her fellowship in pain medicine at Johns Hopkins and anesthesiology residency at Georgetown. A fun fact about Dr. Christensen is she was born in Poland and grew up bilingual, speaking Polish and English, and her love of languages continues as she has since studied Spanish, French, Greek, and Italian. All right. Well, our format for today is an interview style discussion, and then we'll open up for some questions from the audience. So, number one, we'll just jump right into it. Let's start by identifying who's the ideal patient. For me, as the palliative care consultant, to consult anesthesia, and maybe the flip side too. What are some red flags of who is clearly not going to be a good candidate for this?
Sure. So I think in my experience, most of our candidates come from the inpatient world, and I think that's for a reason. I think in the inpatient world, a lot of people are coming in closer to end of life because one of my palliative care colleagues once told me that the way they judge prognosis is that as you reach toward end of life, you have more and more events, and those events can be hospital admissions, those events can be falls, but any kind of medical events, they judge prognosis based on that. And so admission into the hospital is a big event, which probably means we're nearing the end of life. And that's when these epidurals really are most appropriate, because you want to kind of capture someone in the last 3 months of their life, and even better, like the last couple weeks of life, because of the technical issues that can happen with epidurals that stay in for longer than months. So that's kind of like an overarching time frame of kind of who you're looking for. So it's usually people that are in the hospital that have severe intractable pain, usually local or regional, usually chest, abdomen, or pelvis. I would say there are some exceptions to that with the limbs. And then it's people who are, managed on opioids, but opioids aren't enough. You've tried a lot of different adjuncts. Those really aren't working either. And so then at that point, it's time to maybe think about consulting an anesthesiologist to see if an externalized epidural might be worth considering. And then there's a whole bunch of considerations that the anesthesiologist will take into play of like, are there any active coagulopathies? What kind of medications are they on? A lot of patients with cancer are on anticoagulants towards the end of life, but sometimes those can be stopped because it's kind of a risk-benefit analysis. But yes, I will also say that just because patients are in the outpatient world doesn't mean they're not candidates. I have just personally found that those patients are usually less um,
Mm.
ready to be immobilized, which the epidural does for most patients. Most patients will be bedbound once that epidural is in because their legs will just be too weak to reliably walk, which also means they need a urinary catheter. Whereas inpatients are usually already at that point.
I think I'd miss one of my misunderstandings is I assumed this was primarily for pelvic type pain, lower abdominal pain. That's not the case, it appears.
No, not at all. I mean, we can
Hmm.
place thoracic epidurals too for
Hmm.
chest pain. And
Yeah,
I
okay.
think the reason why people think maybe pelvic, because the biggest association with epidurals and the most common use, I think, is with labor.
Yeah.
And so people think, okay, pelvic pain, but really in reality, like chest, abdomen, pelvis,
Hmm.
all very reasonable. But again, local or regional pain. You don't want widespread pain from like widespread metastases or widespread pain for whatever reason. It's never going to be able to cover that. An epidural can cover somewhere between 4 to 7 dermatomes, depending on how well it's working.
All right. I appreciate that. So last weeks of life, ideally, severe intractable pain and something reasonably localized. All right.
Hmm.
Lovely.
Local, regional.
Local
Hmm.
region. All right. Um, And then what goes into this procedure? Can you show us a little bit about what it looks like and how people manage it?
Sure. So this slide right here shows kind of the basics of tunneling the catheter. So the midline, I don't know if you can see my cursor, the midline needle here, that's the one that's actually entering the epidural space. And then you can see the catheter that's coming out that needle. So this is the epidural needle. This flank needle is the tunneling needle. And that is what you bring the catheter away from the site, as far away from the site as you can of the epidural space. And the reason why we do this is because it makes it less likely to get infected because the skin exit site where the tubing is leaving the body is further away from where the tubing enters the neuraxium, and that's the goal. So even if there was a local infection, it would be along the flank, less likely so along the midline. But again, like these patients, the goal is to really put in these externalized epidurals when they have weeks left. And epidurals can stay in for weeks. They also can stay in for months, but obviously the longer a single epidural stays in, the more likely it is to have complications. So this is kind of a way of kind of potentially limiting some of those medications. And it also probably makes it less likely that the epidural is going to get pulled out. And that's because there's kind of an L-shaped bend in the catheter. Which, that kink, so to speak, just makes it harder to pull out. And then it's all taped to the side, as you can see in this last picture, once that catheter is pulled through on the flank side. So a tunneled epidural sounds really, really fancy, but in reality, it's just like a labor epidural. It's just a second needle is brought in to bring that catheter out to the side of the flank, and then it's all taped down. So
Are
it's a
the
procedure that anesthesiologists do. You don't need a surgeon for this.
ideally done in the inpatient world or something that could be done
No,
on
it
the
can be done
outpatient?
in it
Yeah.
can be done in any kind of
Mhm.
sterile procedural suite.
Okay.
Yep. So you can do it like I practice chronic outpatient pain, and we
Oh,
have procedural suites where we do our procedures. It could be done in there. It can be done in, the operating room, but it doesn't need to be. I mean, some epidurals, in fact, are even done bedside. That's a possibility too. Like for labor epidurals, they're just done in the laboring room. So anywhere where it's clean enough to do an epidural is fine.
lovely.
Mhm.
And then I know you recently published a retrospective descriptive study about 7 patients that you've placed tunneled epidural catheters for intractable cancer pain. Can you give us a couple of highlights from that?
Sure. So this is the table that looks at the outcomes from that case series. And basically, what it showed is that epidurals work really well for some, but not for all. And we looked at kind of the different cancers that patients had to try to figure out if there were any trends. So we looked at patients with soft bone and soft tissue cancer, digestive system cancer, endocrine cancer, reproductive system cancer. All these patients got epidurals. We looked at their morphine equivalents before and after the epidural was placed, and then we looked at the change in those morphine equivalents that happened in the days following. And the most of the patients had the epidural in place until they died. And so you can see epidural in place in days, and then you can see epidural um, placement to death. So, yeah, most of these patients kept their epidural in the entire time. The other thing that we did in the study is we pulled information about what patients said about their epidural, and this I found super interesting. So, like for example, this first patient, they were in home hospice, and they said the relief from the epidural was limited, and the complication of the epidural was they continued to have intractable pain. Um, so, it didn't help. Whereas some patients, said they were comfortable and had no complications. Some patients said they had no pain, but then they had nausea and vomiting. And what that nausea and vomiting was from, we don't know. This last patient, fairly good, then difficult. Well, her catheter um, came out, so it dislodged and wasn't replaced. And so she kind of had that experience with the epidural and without the epidural, and everything was great until it came out. And that I would say is the most common complication of these epidurals is that they can dislodge or kink or stop working. So it's not a perfect solution, but it's out there and it is good for some.
There was a recent Cochrane review that took a look at celiac plexus blocks, and it also described this very bimodal distribution. Some people had a really good response, and some people did not. It didn't seem like there was a lot in the middle. Is that your personal experience as well with the epidurals?
Yeah, I would say, and actually, so most of my practice is treating patients with cancer, and most of those patients are nearing end of life. And I also do that celiac plexus neurolysis procedure.
Yeah.
And I would say that rings true. Like some patients have these dramatic responses to the epidural, to the celiac plexus
Hmm.
procedure, and they're just so grateful and um yeah, it makes my job extremely fulfilling. And some patients, it doesn't work and it's hard to understand why from like a scientific standpoint. One of the theories I have is, the longer that someone's been in intractable pain, the more there's chemical processes that occur in the brain and the spinal cord that make them more used to being in pain. And so it's possible that some of these patients that don't respond to basically being numb, in that entire area where you would think they have pain is because it's past that point. It's in the brain and the spinal cord where that pain is now being processed, and we're not numbing the brain and the spinal cord with these procedures. So one theory, and that's called central sensitization.
Gotcha.
Hmm.
So I personally have never seen anyone leave the hospital with an epidural.
Hmm.
I would love to hear some of the practical limitations to accessing this option because it sounds like you guys have this wonderful resource that maybe most people might not have access to.
Yeah. Well, I mean, I guess we're unique, but we're also not because I trained on the East Coast at Hopkins
Hmm.
and we had this availability there too, which gave me the idea of when I started on faculty at OHSU that, hey, well, it worked there, so we can work here. It's just a matter of figuring out the system. And the way we did that is we just started contacting local hospices, um, both inpatient and home hospice agencies, and said, hey, we have this service. And so patients that, have severe pain that we typically meet in the hospital, would you be open to getting trained and learning how to manage these patients once they go home with these epidurals? And a lot of hospices were actually very open to it because pain is really difficult, particularly like intractable pain, and it's stressful for the patients. It's stressful for the hospice team. It's stressful for caregivers. It's stressful for everyone. And so I feel like it wasn't a battle to say, hey, we have this. What would you think about getting trained and learning it? And they said, absolutely. Where do we sign up? And so then it was just a matter of teaching the hospice providers of like, take a look at that exit site and showing them the pictures of the tunneled epidural. And this is where you need to look, but also look at that midline site for any signs of infection, redness, swelling, drainage. Call us. We always have someone on call. And so looking at that site daily, typically by the caregiver, and once a week by the hospice nurse, assuming it's home hospice. And then the bag that has the medication that's being infused into the epidural catheter only needs to be changed once a week. And so that once weekly rounds that the hospice team takes into the patient's home is enough to basically change out that bag, make sure there's no obvious disconnection of the tubing, ask the patient, is the epidural still working well for your pain, take a look at that site, and that's it. And then we support them and we make sure that they know that they're supported, that if there's any questions or concerns or they don't know what to do, now in the advent of, virtual visits like we're doing right now, like they can just get on the video with us, show us what they're concerned about, and oftentimes we can walk them through it.
Gotcha. It all comes down to relationships that they have access to you guys.
Mm-hmm. Mm-hmm. And we cover a huge state. I mean, Oregon is, well, probably similar to Illinois. Like, or it's a big state, and we support rural hospices, urban hospices, everything in between. So it's anyone can do this.
And I can't imagine that they're all that common. So it's not like this is going to be an incredible burden on the anesthesia team. This is going to be something pretty rare.
Exactly. Exactly. And I mean, this subset of patients that I published, so these are all the patients that we did. I think it was over like a 3 or 5 year period, something like that. So it's like one per year, if that, but one per year that everyone was having a hard time managing the pain. And so they ended up calling us. And like we can see from this, sometimes it worked out, sometimes it didn't. But if you can help half of them and they die in peace, I mean, that's still half of them that had that opportunity.
Do you typically use a trial dose to make sure it works or to make sure they have relief before you place it or
No, because the epidural catheter, so if we have any suspicion that the patient's going to go home with the catheter or go to a inpatient hospice setting with the
Mhm.
catheter, we go ahead and just tunnel it
Hmm.
because it spares them an extra procedure. And that tunneling, like you saw on the first slide, is just one additional needle from the flank. And so we numb that, we go ahead and tunnel it. It adds maybe 5 minutes to the procedure, but then at least they have the option of going home with it versus if we did kind of like a test catheter and ran
Mhm.
that for a little while, we maybe save 5 minutes on the procedure time, but then they would have to have a second procedure where that original one comes out and then we put a new one in, which again isn't a big deal, but it's a second procedure for the patient and someone who's end of life. We try to spare them that.
Gotcha.
Hmm.
And then epidurals are one of two neuroaxial options. Can you give us a couple of highlights about some of the key differences between the epidural and the intrathecal?
Hmm. So I would never put in an intrathecal catheter that's external for end of life pain. And that's because when you're infusing medication directly into the CSF, there's just a higher risk involved. A higher risk of major complications, medication, errors can be disastrous when it's intrathecal versus epidural. Like the epidural space is just a lot more forgiving, is the way I would think about it. That being said, we do intrathecal pumps for patients that have a prognosis that's longer than 6 months. And so, still patients who are typically in their last year of life, but just have a longer prognosis that we work with our palliative care team and the oncology team to try to get a sense of that prognosis with kind of what I started with of, seeing how often events are happening. So if major medical events are happening yearly, then we think they have years to live. If they're happening monthly, then we think they have months to live. If they're happening weekly, we think they have weeks to live. So someone who's, having medical events maybe yearly or monthly, we would consider for an intrathecal pump. The big difference with the intrathecal pump that I think a lot of people don't realize is it's a side effect driven therapy. And what I mean by that is it is not like numbing. They're not really going to be numb. And the amount of opioid in it is well, not the amount, but like the opioid in it isn't a super opioid. So I think the misconception with intrathecal pumps is, oh, I'm going to put this in and this opioid is going to work so much better than the oral or the IV opioids that I'm using or transdermal opioids that I'm using now. But that's not the case. Where the intrathecal pump shines is it is used when opioids are helpful, but dose titration of those opioids is limited by side effects. So patients that are very somnolent as you go up on their opioids, very constipated, whatever the opioid side effect is, Because you're delivering that small amount of opioid directly into the cerebral spinal fluid, those side effects drop down to almost nil. And so it's an ability to basically target those mu receptors by those opioids without getting all the side effects. The numbing is like an adjunct. Like, unlike an epidural, they're not going to be numb in several dermatomes. And so, yeah, it's an adjunct, just like duloxetine is an adjunct. You wouldn't use it to ever like actually numb. And so it's a different subset of patients that we consider for an intrathecal pump entirely than an externalized epidural. And I would think the biggest decision point of even kind of early on is what is prognosis.
Lovely. Thank you. That's really helpful.
Mhm.
My last question before we open it up for any audience participation is I know that epidurals are outside my palliative care scope, but I might inherit somebody. Or maybe I work at a smaller hospital where anesthesia might not be available right away and I've got to help manage. Can you give us some tips for how to do these conversions?
Oh, yeah, sure. So I have a slide for that. So the way I do this is I start with whatever opioid I have, I convert it over to morphine equivalents. And that all my palliative care colleagues, and I'm sure yourself, are also comfortable with.
Yeah.
And so then once you have the morphine equivalents, to get to intravenous, it's a conversion factor of 3. To get to epidural, it's a conversion factor of 30. To get to intrathecal, which you probably wouldn't see it because, again, most people don't put in intrathecal externalized catheters, it's 300. And so, yeah, it's that. That's what I do. It's that simple.
Okay. This is the chart that I've seen
Okay.
most often. And it seems to be the one that's the most widely accepted, though my my limited understanding of these conversion tables is that it's
Mm-hmm.
not necessarily based on a lot of evidence base, but more practice and I don't know, rough consensus.
Mm-hmm. But I would say doing these, like this stands up.
Gotcha.
Um,
Yeah.
the other thing I will say is like when we're talking about these externalized epidurals, it's kind of the opposite of the intrathecal pump. So the intrathecal pump, I think of the opioid to be the primary medication, and then the local anesthetic to be the adjunct.
Mm-hmm.
It's the opposite of how we think of epidurals.
Mm-hmm.
So with epidurals, I'm thinking of the local anesthetic as the primary medication and the opioid to be the adjunct. And so really like I wouldn't be too worried about um I wouldn't be too worried about even maybe necessarily converting your opioids for an epidural. You could keep oral or IV opioids and then just run an epidural with local anesthetic, whether it's bupivacaine or whatever you have available in your hospital, ropivacaine, because it's really the local anesthetic that numbs and makes the epidural shine, um, if that makes sense.
It does.
So
Thank you. Yeah.
you might not even need this table.
Lovely.
And
All right.
actually, go back just one slide, you'll be able to see that most of my patients that for the epidural medication, so it was just local anesthetic ropivacaine, and then bupivacaine with an adjunct of sufentanil, but most of these, like the primary medication is really the local anesthetic.
All right. We've got one question in the chat. Eve asks, do you feel it's appropriate for patients with a prognosis of just days if it's shorter than that, weeks to months?
You know, I do, but there's a if to that. So it's if the patient wants it, if the patient is suffering enough and their pain is intractable. Um, I don't know how many of you have ever had a labor epidural, but it's like you're laboring and it hurts, and then all of a sudden the anesthesiologist comes and they put in the epidural and it's like, ah. So I see that same phenomenon happen with the patients who are end of life, where it's like for the ones that it works for, it's like they're suffering, they're suffering, they're suffering. And then you put in the epidural and it's like, ah, exhale. And it's like, what a better way to die than that?
Hmm. I could imagine I have patients where they have many areas of metastatic pain, but perhaps one of them is by far the one that's bothering them the most, even though it may not be entirely local regional. Maybe something like that would be useful for that one spot area that is by far the main source of their suffering.
Maybe,
Maybe.
maybe. I mean, in my experience, what happens is you take care of one area of pain that you're like, this is it. And if
Hmm.
we take care of this, it's going to be,
Hmm.
we're going to arrive, we're going to be there. And then the other one just flares up.
Gotcha.
Um, and so I think sometimes, I think not to say it's not worth a try,
Mhm.
but that being said, that has been my experience that if there's really like um, reason to have multiple areas of pain because there's tumor in the shoulder and there's tumor in the pelvis and there's tumor in the leg, those will interchangeably unmask depending on which one you're treating.
Gotcha.
Mhm.
Eve, I see you have your hand up. Did you want to unmute and ask something?
Yeah. Yeah, I was going to kind of following up on the question. I feel like what a great alternative for um, like more of a palliative sedation type of proportional sedation when somebody has gotten so close to the end and they're just so miserable more from the pain, but then their agitation and everything gets out of control. What are your thoughts on that?
On palliative sedation,
Yeah, and the proportional sedation, like using an epidural prior to reaching for that.
yeah, I mean, I think it kind of goes back to like what are the patient's goals? And like some patients I think will tell you like, I am done being aware and present in this world. And some patients aren't done because maybe they want to still be present with their family while they die. And I think that's a personal choice. And I think we've all probably seen patients make um, those kind of disparate decisions. And so I would say, uh, if the patient wants to be present, the epidural enables them to do that, but have that moment, hopefully. Or if they're just kind of done with it, I think, sedation makes a lot of sense.
Then I see Amy's got a question. I'll have her unmute, and I think that'll be our last question of the day.
Awesome. Hi, Sandy. It's Amy Pearson. Good to
Hi,
see you.
nice
Hi.
to see you too.
Okay. So my questions, I'm a pain anesthesiologist too. So my question is a little bit more on like the administrative side. We don't have anything like this at Aurora currently. And my question for you is how does your structure work to support something like this? Because I could imagine if a tunneled epidural gets falls out 3 hours away from you in the middle of the night, how do you kind of manage all of these uh complicated things for the state?
Totally. And this is the part that's kind of hard, and you can almost see it in this data too, is that when the epidural stops working, then we typically recommend that the hospice goes back to whatever they were using, before. We don't typically bring the bring the patient from 3 hours away back into the hospital to put the epidural back in. And that's why, the last patient on my outcomes, it was fairly good and then difficult because her catheter dislodged. And that can be disappointing and heartbreaking for everyone. But then it's going back to the usually oral opioids to kind of manage the pain. Um, yeah, does that answer your question, Amy? The other thing I was
Yeah.
administratively, like the way process wise we get this done is I have a cancer care coordinator. She's a nurse. She's absolutely fantastic. She is my rock. And so she does a lot of the behind the scenes management of coordinating between the inpatient stay and the infusion service that's going to bring the infusion equipment to the hospital, and that's the infusion equipment the patient's going to go home with. And so they go ahead and connect the patient to the infusion equipment that they're going to go home with in the hospital before discharge. They go in the ambulance home with that infusion equipment working, and we verified in the hospital that it's working before discharge, and then they're already set up in their home environment, ready to go with the infusion running. And from there, it's just the hospice team coming in once a week to check on the system. Um, And then they're given, phone numbers of who to call and typically it's the caregiver of, this is who to call if you're having any issues with this. And we have a team of on-call. It's kind of like an acute pain service that takes those calls. Mm-hmm.
And do you ever have, we ran into this issue where I used to work where the pharmacy had to do some kind of testing of the opioid and the bupivacaine, and it had to sit out for 30 days for them to measure its stability and all that. Do you have those kind of issues at all?
I haven't. That being said, our infusion company is constantly changing because they seem to be going out of business often. I don't know why infusion companies do, but no, none of the infusion companies have delayed us by 30 days. Most of the infusions are available within there's the durable medical equipment, so the actual pump itself, that the is separate from the medication company. So there's the durable medical equipment company, and then there's the actual medication company. So it's coordinating with both of those to get kind of everything in one place. And that coordination process usually is on the order of days, 1 to 3 days before it arrives in the hospital. And so usually what happens is these patients, get the epidural, and then we immediately start coordinating if the intent is that they go to hospice. And then they're able to be discharged within 1 to 3 days. Mm-hmm.
Awesome. Thank you so much.
Nice seeing you.
Good to see you too.
All right, Sandy, this was lovely. We really appreciate your time with us. Thank you.
Thank you for having me. It was fun.
All right, everybody. Have a wonderful weekend. Toodles.